The purpose of the preoperative airway examination is to identify the patient who may be either difficult to intubate using conventional direct laryngoscopy or difficult to ventilate with a bag and mask system. The patient should be examined in an upright position. The airway examination is performed by having the patient open their mouth as wide as they can and protrude their tongue as much as possible. A modified Mallampati class is assigned based on the ability to visualize the oropharyngeal structures. An examination of the patient's teeth is then performed. Missing, capped, broken, chipped, or prominent teeth are identified. Attention is paid to the upper 4 front teeth, as these teeth are at particular risk of injury during direct laryngoscopy and intubation. Mouth opening is then assessed. The 2 main factors altering a patient's ability to open their mouth are their thyromental joint mobility and the configuration of their front teeth. Typically, the distance between the upper and lower front teeth should be about 5 centimeters, or slightly more than the width of 2 fingers for intubation using a conventional laryngoscope. Edentulous patients are generally not difficult to insert a laryngoscope into their mouth. Cervical spine mobility is then assessed by having the patient extend their neck. The thyromental distance is a distance from the underside of the chin, or mentum, to the superior border of the thyroid cartilage. This should typically be at least 6.5 centimeters in an adult, or slightly more than the width of 3 fingers. An optional upper lip bite test has been used to assess the ability of the patient to protrude their mandible. Patients who can fully protrude their lower mandible such that their lower teeth can bite their upper lip border are identified as having a Class 1 upper lip bite test. Patients with a Class 3 upper lip bite test are unable to bite their upper lip and may be more difficult to intubate using conventional direct laryngoscopy. The word bones has been used as a memory aid or mnemonic to recall common predictors associated with difficulty in providing positive pressure ventilation using a bag and mask system. The predictors include patients with a beard, as facial hair may make it difficult to obtain a seal between the mask and face. Obese patients often have abundant lax soft tissues that can readily obstruct the upper airway. In elderly patients, the flexibility of the tissues and ligaments is reduced, which may make direct laryngoscopy more difficult. Elderly patients are also often edentulous. The absence of teeth facilitates the collapse of the oropharyngeal airway when a mask is applied to the face. Patients who snore often have obstructive sleep apnea, which is associated with abundant lax upper airway tissue and difficulty providing positive pressure ventilation with a bag and mask system. It is important to identify predictors associated with difficulty in performing direct laryngoscopy, as well as predictors of difficulty in providing positive pressure ventilation using a bag and mask system. Inability to intubate or ventilate an apneic patient is referred to as a cannot ventilate, cannot intubate emergency. The CVCI scenario is a dire emergency that can rapidly deteriorate to a hypoxic, bradycardic, arrested state if not corrected. Insertion of a supraglottic device such as an oral airway, nasal airway, or LMA device can be a life-saving maneuver in this setting, permitting effective ventilation and oxygenation of the apneic patient. A past history of difficulty with intubation and previous anesthetic records can be useful sources of information when formulating a plan for airway management. Patients requiring general anesthesia that are identified with predictors of a difficult direct laryngoscopy and intubation may be considered candidates for advanced airway intubation techniques such as video laryngoscopy or flexible bronchoscopy and intubation using local anesthesia and sedation. A full examination of the airway may not be possible in patients requiring emergent intubation. Difficulty with bag mask ventilation and intubation in these patients should be anticipated, and clear backup plans in place should the initial plan of management fail. These are discussed further in chapters 6 to 9 of the Ottawa Anesthesia Primer. Finally, as an interesting aside, very rarely the epiglottis can be viewed at the base of the tongue. Like the Loch Ness or Sasquatch monsters, this is truly a rare sighting. These patients are assigned a Mallampati class of 0 and in general are not difficult to intubate or ventilate.